স্যার আমরা এখন শুরু করতে পারি।
Thank you. So, Dhiman.
Respected panelists. Hello.
Yes, Dhiman, we can hear you.
Respected panelists, moderators, teachers, and colleagues. Today, welcome you all to our National Heart Foundation class on every Wednesday. Today, I am very much pleased to be a moderator in a session where Professor Fazila Malik Madam will give an important lecture on intervention of ST segment elevation MI. And the other speaker is Dr. Kalimuddin, who is the assistant professor of our hospital. We are greatly proud to be have one of the great teacher and intervention cardiologists of the country, Professor Ghulam Azam, with us as panelist. So at the very beginning, I want to request Professor Fazila Malik Madam to say a few words regarding this program and this occasion. Madam, please.
So thank you, Dhiman, and welcome, Professor Azam. We are really grateful that you are here with us. Now, today actually is a very special day for us. We started doing virtual classes at the height of COVID last year. We started around June, I think, June, July. And at that time, the COVID situation was really bad, but we felt that our students needed classes and we started virtual classes. And now, since then, there's been such a lot of virtual classes happening. And I think not only us, other organizations have come up with great classes, and I think the students have benefited. Now, as the situation improves, as we get vaccinated, the situation is a lot better now. And we feel that we don't have to have the Wednesday classes every week now. And like all good things, this Wednesday class is also coming to an end, but we will still continue having at least one monthly class or a grand round where we will dedicate the entire hour to a very special topic, like maybe OCT or IVA, so that our students can benefit. And we will announce the dates. Maybe we plan to have it last week of Thursday, and maybe in the afternoon, sometimes in the evening, whatever suits our panelists and other experts. And before we say goodbye, I have to say thank you to all the teachers, all our guests, panel of experts, and all our students who made this program successful. And I think the most important thanks that I would like to say is to Incepta and to Nurul Afsar, who was there during this entire session with us. He has been a rock. He has really supported us, and I'm truly grateful to him. And I'm truly grateful to all of you. So this has been a great experience, I must say, for me personally. I learned more than anyone. I think I really benefited from these classes, and I'm grateful to all the teachers who took their time to teach us, all the panel of experts who gave their expert opinions, and thank you so much. And from all the students of cardiology in Bangladesh, I would like to say thank you to all of you. And without further ado, I would request our moderator, Dhiman Bonik, to proceed with the session. So if Dhiman is, maybe he's traveling, he's going back home, so maybe he's having some problems. So without further ado, I would request Dr. Kalimuddin to give his first presentation. Now, Kalimuddin requires no introduction. He is a brilliant researcher. All our research work is done due to his active involvement. He is a great clinician, a great interventional cardiologist, and above all, a great human being. So without further ado, I would request Dr. Kalimuddin to present his lecture.
Ma'am, thank you.
Kolim bhai, please share your screen.
share হচ্ছে না
একেবারে অফ করে দেন। এবার শেয়ার করেন এবার।
যেটা নাই আচ্ছা আমার লেকচারতে স্যার এই যে আছে স্যার মিনিমাইজ হচ্ছে না স্যার।
তাহলে ইয়া করেন আপনি, অফ হয়ে যান, অফ হয়ে মিনিমাইজ করে আবার ইয়া করেন। ইয়েস
স্যার আপনার প্রেজেন্টেশনটা কি পেয়েছেন স্যার? কোথায় আছে প্রেজেন্টেশনটা?
প্রেজেন্টেশন ইতে আছে, ডেস্কটপে আছে।
ওকে, সমস্যা নেই। তাহলে স্যার আপনি স্ক্রিন শেয়ারে গিয়ে ওই এইমাত্র যেমন শেয়ার করলেন ওভাবে একটু শেয়ার করে নেন।
এখানে দেখতে আসছে না, এই জন্যই।
তাহলে বেস্ট হচ্ছে আপনি অফ হয়ে যান, লিভ করেন, লিভ করে আবার জয়েন করেন, লিভ করে প্রেজেন্টেশনটা এক জায়গায়।
If there's any problem, I can start my presentation, and during that time, Kolim can sort his presentation, and that also we can do, whatever works. Kolim?
Kolim,
So while Kolim sorts this out, what are your thoughts on this, Ashok Datta, that about our 1.5-year journey during this COVID classes, virtual classes? Any comments?
Yes, ma'am. Thank you, ma'am. Actually, this is a different adventure. Like before that, we never think that virtually we can do such lot of things. Before, just before COVID, even during transmission of a live case, we have to hire the authority from the television channel and etc. But nowadays it becomes very much easy, and virtually the impression to the student, to the audience is less, because in person the impression is different. Face-to-face expression and change of facial expression is very important, but here impression is less. But anyhow, the communication make us very much easy to communicate all over the world. So many EuroPCR, TCT, our program
Sky.
and all other BIT and everything we can enjoy it very easily, and that's I think students are getting
The
more
beneficiary.
benefit here if they are very much attentive, and we have completed more than 50 classes like this. So if they just recapitulate and just go through all the recorded things, I think they will in future they will get much benefit from these lectures.
I think so too. Do we have Kalimuddin ready with us? And Dhiman has not yet reached home. Is Dhiman with us? Professor Ghulam Azam, do you want to make any comments before Kalim joins us? So Professor Ghulam Azam, this is another thing, you know.
Yes.
Thank you, madam.
Yes, please.
Thank you, madam. First of all, I give you a special thanks because you arranged such a wonderful teaching program from your institute. So I must give special thanks to you and your team because you take the initiative. I must say you create a history because at least you right now, today I think so far I can remember, this is 50th lecture of your institutions.
Indeed,
so
yes.
First half century, and now you create a resourceful history or documentation in your institution. This 50 lecture will give the future fellows some insightful thought for their future career planning as well as their career build-up. So And one thing I should mention you is because the last week in Twitter, along with mamas and there are Dragstone as well, everybody's joined with this tweet. Actually, how we should look the future program. Future program should be in hybrid format, which is the preferable. They all are suggested for hybrid format is favorable, as because for the documentation as well. Initially, the program was held, but they should keep recording for future preservation. Right now, hybrid system in such a way, everything can be documented very nicely. That's why they all are appreciated for hybrid program. So, sir, madam, I think you should continue your program, not in regular weekly, at least twice or once monthly, so that every new innovative approach and any learning cases or thoughtful cases, thought-provoking case, I think everyone can share by online platforms so that everyone will be benefited. Thank you, madam. This is my small comment from my side.
I think Dr. Kolimuddin is ready with the screen share. Kolim bhai, are you ready?
Yes, sir. Yes, sir.
Yes. So you can start.
Yes, sir.
You can
Thank
start
you.
now.
Yes, sir. Thank you. Honorable expert panel, respected moderator and learned audience, Assalamu alaikum. I am Dr. Mohammad Kolimuddin, presenting medical management of STEMI patient. Medical management starts in emergency department. Oxygen inhalation if oxygen saturation less than 90%, IV access, cardiac monitoring, loading dose of aspirin 300 mg. If clopidogrel and clopidogrel 300 mg, 600 mg if primary PCI, or ticagrel 100 mg, or prasugrel 60 mg. Statin loading dose PPI and heparin 5000 IV bolus. Narcotic analgesic, morphine or pethidine, antiemetic, nitrates if raised BP or left ventricular heart failure. Oxygen indicated in patient with hypoxemia if oxygen saturation less than 90%. Supplementary oxygen may increase coronary vascular resistance. So oxygen should not be given if patient oxygen saturation more than 90%. Opioid should be considered to relieve pain. In the absence of history of hypersensitivity, morphine sulfate is the drug of choice for pain relief in patient with STMI, particularly those whose course is completed by acute pulmonary edema. It can alleviate the work of breathing, reduce anxiety and pulmonary venous pressure. A mild tranquilizer, usually benzodiazepine, should be considered in very anxious patients. National Heart Foundation Acute Registry NAMID, which includes 6,600 patients over 5 years from 2015 to 2019, showing 19.3% patient received thrombolytic therapy, 15.5% patient received primary PCI, 9.2% pharmaco-invasive therapy, and PCI only 16.3%. Medical management 39.7%. So in our hospital, only 44% patient receive reperfusion therapy. What are the factors selecting the type of reperfusion therapy? For patient with STMI presenting to a PCI capable hospital, primary PCI should be accomplished within 90 minutes. For patient presenting to a non-PCI capable hospital, rapid assessment of the time from onset of symptoms, the risk of complication related to STMI, the risk of bleeding with fibrinolysis, the presence of shock or severe heart failure, and the presence of shock or severe heart failure, and the time required for transfer to a PCI capable hospital must be made, and a decision about administration of fibrinolytic therapy reached. Goals for reperfusion therapy. System delays to reperfusion are correlated with higher rates of mortality and morbidity. So total ischemic time is the principal determinant of clinical outcome. This figure showing total ischemic time, and there is which consists of patient delay, system delay, maybe the increased total ischemic time. So target is reduced total ischemic time. What are the goals of fibrinolysis? The goal of fibrinolysis therapy is to inject bolus of fibrinolytic within 30 minutes from STMI diagnosis. Fibrinolytic therapy prevents 30 early deaths per 1,000 patients treated within 6 hours after symptom onset. The largest absolute benefit is seen among patients at highest risk, including the elderly, and when treatment is offered less than 2 hours after symptom onset. What are the indication of thrombolytic therapy? Ischemic symptom less than 12 hours. It is class 1 indication, both ECC and ESC and AHA guideline. And evidence of ongoing ischemia from 12 to 24 hours after symptom onset, and a large area of myocardium matrix or hemodynamic instability, a thrombolytic therapy can be given. It is 2A indication. So a thrombolytic therapy we can give up to 24 hours. A fibrin-specific antigen is recommended like tenecteplase. A half dose of tenecteplase should be considered in patient aged 75 and more than 75 years. It is 2A indication. And antiplatelet co-therapy with fibrinolysis are aspirin and clopidogrel in addition to aspirin. Dual antiplatelet therapy is indicated for up to 1 year in patient undergoing fibrinolysis and subsequent PCI. In these cases, PCI, prasugrel and clopidogrel, prasugrel and ticagrelor is preferable over clopidogrel because of more rapid onset of action, greater potency, and superior to clopidogrel in clinical outcome. And anticoagulation is recommended in patient treated with lytics until hospital revascularization or hospital stay up to 8 days. The anticoagulation can be enoxaparin, unfractionated heparin, or fondaparinux in case of streptokinase. What are the contraindications of fibrinolysis? Absolute contraindications are any prior intracranial hemorrhage, non-structural cerebral vascularization, non-malignant intracranial neoplasm, primary or metastatic, ischemic stroke within 3 months, except acute ischemic stroke within 4.5 hours, suspected aortic dissection, active bleeding or bleeding diathesis excluding mens, significant closed head or facial trauma within 3 months, intracranial or interspinal surgery within 2 months, severe uncontrolled hypertension unresponsive to emergency therapy for streptokinase prior treatment within the previous 6 months. Relative contraindications are history of chronic severe poorly controlled hypertension, significant hypertension on presentation, systolic blood pressure 180 millimeter mercury or diastolic blood pressure 100 millimeter mercury, history of prior ischemic stroke within 3 months, dementia, known intracranial pathology not covered in absolute contraindication, traumatic or prolonged more than 10 minutes CPR, major surgery less than 3 weeks, recent internal bleeding within 2 to 4 weeks, non-compressible vascular puncture, pregnancy, active peptic ulcer, oral anticoagulation therapy. Comparison of fibrinolytic agents. Fibrinolytic agents can be classified into fibrin specific and non-fibrin specific. Non-fibrin specific is anti-streptokinase, which patency rate is 60 to 68%. Tenecteplase, which is highly fibrin specific, with patency rate 85%. Doses of fibrinolytic agents and antithrombotic co-therapies. Streptokinase should be given 1.5 million units over 3 to 60 minute IV, and tenecteplase single IV bolus 30 milligram if body weight less than 60 kg, and 35 milligram if body weight 60 to 69 kg, 40 milligram if body weight 70 to 79 kg, if 45 milligram if body weight 80 to 89 kg, and 50 milligram above 90 kg. Aspirin starting dose is 150 to 300 milligram orally, or 75 to 250 milligram intravenously if oral injection is not possible, followed by maintenance dose of 75 to 100 milligram per day. In ACC-AHA guideline, loading dose is 162 milligram to 325 milligram, and maintenance dose 81 to 325 milligram per day. Clopidogrel loading dose of 300 milligram, followed by maintenance dose 75 milligram per day. In patient 75 or over 75 years of age, loading dose is 75 milligram. And enoxaparin in patient age less than 75 years of age, 30 milligram IV bolus, followed by 1 milligram per kg 12 hourly. And in patient 75 or more than 75 years of age, no IV bolus, only 0.75 milligram per kg body weight 12 hourly. In patient with eGFR less than 30 ml per minute per 1.73 millimeter square, regardless of age, 1 milligram per kg body weight 12 daily. Unfractionated heparin 60 unit per kg bolus, maximum of 400 milligram, followed by infusion of 12 milligram 12 unit per kg with a maximum of 1000 unit for 24 to 48 hours. Target APTT is 50 to 70 seconds. And aspirin and clopidogrel, unfractionated enoxaparin, unfractionated heparin and enoxaparin in patient who did not reperfuse, also same dose as fibrinolytic therapy. Patient with antithrombotic in chronic kidney disease. In patient with chronic kidney disease, 1 to 3 CKD stage, that means eGFR more than 30 millimeter per minute per 1.73 meter square. Loading dose clopidogrel, ticagrelor, prasugrel, enoxaparin same as before. And in stage 3, stage 4 CKD, that is if eGFR less than 30 ml, aspirin, clopidogrel, prasugrel, no dose adjustment, only enoxaparin 1 mg per kg once daily. In stage 5 CKD, if eGFR less than 50 ml per minute per 1.73 meter square, aspirin, no dose adjustment, clopidogrel, no information available, and ticagrelor, prasugrel, and enoxaparin is not recommended. Unfractionated heparin can be given in all stages of chronic kidney disease. Bivalodin and eptifibatide is not recommended in stage 4 and stage 5 chronic kidney disease. Maintenance of anti-thrombotic therapy, aspirin 70 to 75 to 100 mg per day, dual antiplatelet in the form of aspirin plus ticagrelor or prasugrel is recommended for 12 months after PCI unless there are contraindications such as excessive risk of bleeding. PPI in case of risk of gastrointestinal bleeding. In patients who are at high risk of severe bleeding complication, this condition of thrombolytic P2Y2 inhibitor should be after 6 months may be considered. In STEMI patient with stent implantation, oral, if an indication of oral anticoagulation, oral triple therapy should be considered for 1 to 6 months. Dual antiplatelet therapy who did not undergo PCI should be should be continued unless there are contraindications up to 12 months. In patient with IV LV thrombus, anticoagulation should be administered for up to 6 months. In high risk ischemic patient who have tolerated dual antiplatelet therapy without the bleeding complication, treatment with dual antiplatelet therapy in the form of ticagrelor 60 mg twice a day on the top of aspirin for longer than 12 months may be considered for up to 3 years. It is 2B indication, so we can give dual antiplatelet up to 3 years in high risk ischemic patient. In low bleeding risk patient who receive aspirin and clopidogrel, low dose rivaroxaban 2.5 twice daily may be considered. And routine medical therapy. Beta blocker can be administered as early as possible. It is class 1 indication. Intravenous beta blocker in the at the time of presentation in patient undergoing primary PCI. It is 2A indication in the absence of contraindication, and routine beta blocker class 2A indication. But in ACCR guideline, it is class 1 recommendation, routine use of beta blocker. And patient with initial contraindication to use of beta blocker in the first 24 hours after STEMI should be re-evaluated to determine their subsequent eligibility. So, so we should try to restart a beta blocker as soon as possible according to ACCR guideline. AC inhibitor should be given in evidence of heart failure, left ventricular systolic dysfunction, diabetes, or an infarct. This class 1 indication, and ARB preferably valsartan if intolerance to AC inhibitor. And AC inhibitor in all STEMI patient in the absence of contraindication is class 2 indication, also in ACCR guideline. Mineralocorticoid receptor antagonists are recommended in patients with an EF less than 40% heart failure or diabetes and who are already receiving an AC inhibitor or beta blocker, provided there is no renal failure or hyperkalemia. It is also class 1 indication. And in ACCR guideline, it is also same as ESC guideline. And lipid-lowering agent is recommended in all patients with STMI, and target is less than 70 mg per DL for all patients. Nitrates, although nitroglycerin can ameliorate symptoms and signs of myocardial ischemia by reducing left ventricular preload and increasing coronary blood flow, it generally does not attenuate the myocardial injury associated with apical coronary occlusion unless vasospasm plays a significant role. IV nitroglycerin may be useful to treat patients with STMI and hypertension or heart failure. Routine oral nitrates is not recommended in the convalescent phase of STMI. Calcium channel blocker have no beneficial effect on infarct size or the rate of infarction when calcium channel blocker therapy was initiated during either the acute or convalescent phase of STMI. So routine usage of calcium channel blocker is not recommended in STMI. However, calcium channel blocker can be used to relieve ischemia, lower BP, to control the ventricular response rate of atrial fibrillation patients who are intolerant of beta blocker. But in case we should cautiously use in the presence of left ventricular dysfunction, it is harmful. The use of immediate release nifedipine is contraindicated in patients with STMI because of hypotension and reflex sympathetic activation with tachycardia. Non-steroidal anti-inflammatory drugs and selective cyclooxygenase 2 enzyme inhibitor, OX2 inhibitor, associated with increased risk of death, infarction, cardiac rupture, hypertension, renal insufficiency, and heart failure. So they are not recommended in patients with STMI. It is contraindicated, like also as steroidal in STMI. They should not be initiated in acute phase and should be discontinued in patient using them before hospitalization. The selected routine medication in patient with STMI. Physical activity. In the absence of complication, established patient with STMI need not to be confined to bed for more than 12 hours. And unless they are hemodynamically compromised, they may use a bedside commode shortly after admission. Progression of activity should be individualized depending on the patient's clinical status, age, and physical capacity. In patient without hemodynamic compromise, early mobilization, that is sitting in chair, standing, walking around bed, does not usually cause important changes in heart rate, blood pressure, and pulmonary waist pressure. As long as blood pressure and heart rate are monitored, early mobilization offers considerable psychological and physical benefit without any clear medical needs. It is indicated that all STMI patients have ECG monitoring for a minimum of 24 hours. Longer duration needed if patient is unstable. In stable patient should be kept in the CCU or ICU for a minimum of 24 hours whenever possible, after which they may be moved to a step-down monitored bed for an additional 24 to 48 hours. Early discharge within 48 to 70 hours after MI onset should be considered appropriate in selective low-risk patient like patient age less than 70 years, EF more than 45%, single vessel or double vessel is without hemodynamic instability. If early rehabilitation, adequate follow-up are arranged, they can be early discharged to a indication. Influenza vaccination after marketing instruction. It is recently published in 2201 in Circulation. Fuzila Madam also co-author of this article. Influenza vaccination early after an MI or in high-risk coronary heart disease resulted in a lower risk of a composite of all-cause death, MI or stent thrombosis, and a lower risk of all-cause death and cardiovascular death as well as 12 months compared with placebo. Management of complication. Left ventricular dysfunction. AC inhibitor should be used when heart failure to reduce the risk of hospitalization and death. It is class 1 indication. Beta blocker to reduce risk of death, recurrent MI and hospitalization for heart failure. And mineralocorticoid receptor also used to reduce the risk of cardiovascular hospitalization and death. So in heart failure, AC inhibitor, beta blocker, and mineralocorticoid receptor antagonists have survival benefit as antiplatelet therapy and statin therapy. Loop diuretics are used to improve symptoms of fluid overload. Nitrates are recommended in patients to improve symptom and reduce congestion. Oxygen therapy is indicated only if oxygen saturation less than 90%. Patient intubation is indicated in patient with respiratory failure or exhaustion leading to hypoxemia, hypercapnia, or acidosis, and if non-invasive ventilation is not tolerated. Non-invasive positive pressure ventilation, BiPAP and CPAP should be considered with patient with respiratory distress without hypotension. Intravenous nitrates and sodium nitroprusside or nitroprusside can be used to control blood pressure and improve symptoms to a indication. Opiates also can be used in case of heart failure. It is to be indication. Inotropic agents may be considered in patient with severe heart failure and hypotension reflected to medical management. Management of cardiogenic shock in ST elevation myocardial infarction. Immediate PCI indicated in patient if PCI if coronary anatomy is suitable. If coronary anatomy is not suitable for PCI or PCI has failed, emergency CVG is recommended is class 1 indication. Invasive blood pressure monitoring with an arterial line is recommended, and oxygen therapies indicated for respiratory support, and mechanical complication should be treated as early as possible after discussion by the heart team. And if patient with cardiogenic shock, thrombolytic therapy is indicated in as class 2A indication, but in ACCR guideline, it is class 1 indication. Complete revascularization during the in-this procedure should be considered in patient presenting with cardiogenic shock. Intra-aortic balloon pump should be considered in patient with hemodynamic instability and cardiogenic shock due to mechanical complications. Hemodynamic assessment with pulmonary artery catheter may be considered for confirming diagnosis or guiding therapy. And it is also class 1 indication for STMI. And ultrafiltration is used when patient fail to respond to diuretic therapy. Inotropic and vasopressor agents may be considered for hemodynamic stabilization. Short-term mechanical support may be considered in patient in refractory shock. Routine intra-aortic balloon pump is not indicated. This is algorithm for management of cardiogenic shock. Patient should receive with cardiogenic shock medical therapy, inotropic support, ventilatory support, revascularization, repair of mechanical complication, and revascularization. If patient unstable, then short-term mechanical circulatory support. And if no recovery from this, assessment of neurological inorganic function. If favorable neurological function, then mechanical circulatory support for destination therapy or as bridge to cardiac catheterized transplantation. Management of atrial fibrillation. Atrial fibrillation is used in atrial fibrillation for rate control. Beta blocker is used in the absence of clinical signs of acute heart failure or hypertension. Amiodarone used in presence of acute heart failure but no hypertension. And IV digital is in case of acute heart failure and hypertension, it is 2A indication. Cardioversion is indicated when adequate rate control cannot be achieved promptly with pharmacological agents in patient with AF and ongoing ischemia, severe hemodynamic compromise, or heart failure. And management of atrial fibrillation, IV amiodarone should be used when electrical cardioversion to promote electric cardioversion after rate control. And in patient with documented de novo atrial fibrillation during acute phase of STMI, long-term anticoagulation should be considered depending on Charles-Vass score. It is 2A indication. Digoxin, calcium channel blocker, and beta blocker cannot be used for rate control. For rhythm control, it can be used, the rate control, but not rhythm control. Intravenous beta blocker is indicated in patient with polymorphic VT on VF unless contraindicated, and amiodarone in case of recurrent polymorphic VT. Prompt and complete reversal is recommended to treat medical myocardial ischemia that may present in patient with recurrent VT and or VF. Correction of electrolyte imbalance, especially hypokalemia and hypomagnesemia, is recommended in patient with VT and or VF. In case of sinus bradycardia and hemodynamic incompetence or high degree AV block without stable escape rhythm, positive chronotropic medication, IV epinephrine, vasopressin, or atropine is indicated. Temporary pacing is indicated in case of failure to respond to positive chronotropic medication. Urgent angiography with a view to revascularization is indicated if the patient has not received previous reperfusion therapy. Intravenous amiodarone is used despite repeated electric cardioversion. It is 2A indication, and transvenous catheter pace termination or overdrive pacing should be considered if VT cannot be controlled by repeated electrical cardioversion. Radiofrequency catheter ablation at a specialized ablation center followed by ICD implantation should be considered in patient with recurrent VT, VF, or electrical storm despite complete revascularization and optical medical therapy. It is 2A indication. Recurrent VT with hemodynamic repercussion despite repeated electric cardioversion may be treated with lidocaine if beta blocker, amiodarone, and overdrive stimulation are not effective or applicable. It is 2B indication. ICD therapy is indicated in patient with to prevent reduce sudden cardiac death in patient with symptomatic heart failure in NIH class 2, 3 on LVF less than 35% despite optical medical therapy for more than 3 months, and at least 6 weeks after MI who expected to survive for at least 1 year with good functional status. ICD implantation or temporary use of wearable cardioverter defibrillator may be considered less than 40 days after MI in selective patient in case of incomplete revascularization, pre-existing left ventricular ejection dysfunction, occurrence of arrhythmia more than 40 hours after STMI onset, and polymorphic VT or BF. It is 2B indication. In prognosis in almost a patient, almost 25% patient with a few minutes without medical attention died, and half of the death from MI occur within 24 hours of the onset of symptoms. About 40% of all affected patients die within the first month. The prognosis of those who survive to reach hospital is much better, with a 28-day survival is more than 80%. Thank you for patient hearing.
Thank you, Kulim Bhai. Devanda is here.
Yes, I'm here.
Yes.
So, Dhiman, shall we have our lectures first?
Yes,
and then...
madam, you complete your lecture first. Madam, discussion.
Right. Thank you.
Now, I am greatly pleased to declare that now Fazila Malik Madam will be present the invasive treatment of ST segment elevation MI. Madam, like other day, I hope this will be a great lecture for us. Madam, please.
Thank you. That's very kind of you. But actually, Kolim has covered most of what I wanted to say and has made my job very easy. What I want is just a brief recap with the students of what they should know practically. So first of all, we need to have a brief recap of what actually entails atherosclerosis and acute coronary syndrome. Now, we all understand that the atherosclerotic process starts in the coronary arteries very early in age, and even young teenagers might have a fatty streak in their coronary arteries. Now, gradually, a brief recap for the students, gradually the atherosclerotic plaque increases, and when it reaches and causes 70% obstruction of the coronary artery, it leads to chronic coronary syndrome, which we used to previously say or call stable angina. And at that time, when a patient walks, like he will say that when I come from, say, maybe Mirpur Thana to Heart Foundation, I have this compressive chest pain, but when I take rest, it goes away. Now that's chronic and that's a stable situation. Now, what happens, say, if a patient has a 15 or 20% an atherosclerotic plaque, which is causing just 20% obstruction of the coronary artery? It really doesn't give any symptoms to our patient, but suddenly one day maybe the fibrous plaque of that, the fibrous cap of that atherosclerotic plaque ruptures. And we all know that a thin fibrous plaque is fibrous cap is more prone to rupture than a thick fibrous cap. So once the fibrous cap ruptures, what happens is the collagen and the fat of the atherosclerotic plaque gets exposed to the blood. And in the blood, we have platelets and we have the coagulating factors. And all these gets activated when it comes in contact with the collagen from the ruptured atherosclerotic plaque. And suddenly there is a formation of a thrombus at that site. And the poor person who was totally unaware that he has an atherosclerotic plaque, which is not causing any symptoms, suddenly has this acute obstruction in his coronary arteries, and he has sudden onset of symptoms, and that we know as acute coronary syndrome. Now, in the acute coronary syndrome, this is a spectrum, as we all know. When the obstruction is not total, the patient will have symptoms. But depending on whether there is presence or absence of biomarkers in the blood, the patient may have unstable angina or non-ST segment elevation MI. However, if that thrombus should totally obstruct the coronary artery, then that patient is in real trouble. And also we can understand, we physicians can understand that this patient has a total obstruction of his coronary artery, but just looking at his ECG, because there will be ST segment elevation in the leads and which are representing that artery. Like if it's a right coronary artery, you will get ST elevation in 2-3 AVF. If it's an anterior MI, from V1 to V6, depending on the extent of the disease. So in segment elevation MI, there is a totally obstructing thrombus at the site of the lesion, and this is causing problems for our patient. So we have to remember that in case of ST segment elevation, we really need to act very quickly, and time is muscle. So we have to act as early as possible when we are dealing with a patient with ST segment elevation MI, because there is a totally occlusive thrombus at the site of the lesion, which is not allowing any antegrade flow. And if we look at the evolution of a ST segment elevation MI, we know that at 30 minutes, the infarct starts endocardially, and it gradually increases with time. So at 4 hours, it's extending, and usually by 6 to 12 hours, we have a completed infarct. So we have to remember that in case of ST segment elevation MI, we have to act as quickly as possible. So just we would like to, as this is a discussion about the invasive treatment for ST segment elevation MI, let's go through a few cases. Now this is the case of a 55-year-old businessman. He's a resident of Mirpur who came to our emergency at 5 o'clock. So he came very quickly because he lives in Mirpur and we were pretty nearby. He complained of an episode of syncope 1 hour back. On examination, he looked cold and clammy, and his pulse rate was only 30. His blood pressure was 80/50. He's a diabetic with poor control. On top of that, he's also a smoker. So what strikes here for us all is his pulse rate, which is only 30, and his blood pressure, which is 80/50. So we all understand that when a patient goes into hypovolemic shock, his heart rate increases, but blood pressure goes down. Here, his blood pressure is down, his pulse rate is also down. And this is his ECG, which was done in the emergency. And as our students will appreciate, now this is the kind of ECG you will be given in the examination. So it shows that there is a complete dissociation between the QRS complex and the P waves. And when we did the right-sided ECG, there was ST elevation in the right V4. So the diagnosis obviously was acute ST segment elevation MI inferior with right ventricular infarct and complete heart block. So what did we do to this patient? Kaleem has already touched, so I will not go into the details, but obviously we gave him oxygen inhalation. We did monitor his heart rate. In all cases of emergency, we need to open an IV access, which we did. And as the patient had an RV infarct, we gave him normal saline. And we obviously gave him the loading doses of aspirin. And here the P2Y12 inhibitor that we used was prasugrel. You can give any one that you want to and which you think will work for your patient. We gave this patient high intensity statin. Kaleem has already covered that. So we gave him 40 milligrams of atorvastatin. And since we're giving all these drugs, we also gave the patient a PPI for good measure. And this is, the patient agreed, his relatives agreed to a primary PCI. We took him to the cath lab, and this is how his right coronary artery looks. So as you can appreciate, it's totally occluded from close to its origin with huge thrombus burden. And you can also see that there's a temporary pacemaker lead there. So we wired this vessel, and due to the high thrombus load, we did thrombus suction. So now one thing you need to remember is that routine thrombus aspiration is a class 3 indication. So you to do routine thrombus aspiration in all cases, but here, judging by the thrombus load, we thought that this patient warranted thrombus aspiration, and that's what we did. The vessel opened up nicely after thrombus aspiration, and then we proceeded to do direct stenting. And this also we need to remember that in ST segment elevation MI, there's usually quite a bit of thrombus in the artery. And if we do pre-dilatation, then what we do is we are breaking up that thrombus. And when we break up the thrombus, this small fragments of the broken thrombus will embolize distally and will lead to slow flow or no flow. So we don't want that. And that's why whenever we are taking care of a patient and we are treating a ST segment elevation MI, we always try to do direct stenting. And that's what we did. We did direct stenting, deployed our stent, and this was the final result. So you can appreciate that this patient was in cardiogenic shock, had RV infarct, and this was the large right coronary artery that we managed to salvage by primary PCI. So indeed, primary PCI is definitely what works better than fibrinolytics. And when should we do primary PCI for our patients? Indeed, if the patient comes to us with history of ischemic symptoms, which is less than 12 hours, or if the patient has ischemic symptoms and he also has contraindications to fibrinolytic therapy, like Kaleem has already pointed out what the absolute and relative contraindications to fibrinolytic therapy are. If the patient comes with cardiogenic shock or has acute heart failure, if the patient has evidence of ongoing ischemia, even if it's up to 24 hours, or he's in cardiogenic shock and heart failure and it's beyond 24 hours, nowadays in the AAC guideline, it's 48 hours, then we should consider doing a primary PCI. Now let's go to this next case. Now this is a 39-year-old banker who went to MAG Osmani Hospital at 2 o'clock in the night with severe retrosternal chest pain, which was a 4 hours duration. Now he's gone to MAG Osmani. They do have a cath lab, but let's face it, at 2 o'clock, no one's going to come and do a primary PCI for that person, right? And the patient, and we also know that in ST segment elevation MI, time is muscle. So he was diagnosed as a case of acute inferior MI. So we know that the culprit vessel most likely is an RC, and if he has a left dominant system, maybe an LCX. So what should we do? He was actually given fibrinolytics. And after giving fibrinolytics, he was sent to our hospital as a pharmaco-invasive strategy. And this is the angiogram that we did for this patient. Okay, so we expect in our hospital, we are expecting, okay, he's got an inferior MI. He most likely has a right coronary lesion. But we saw that he has a left-sided lesion as well. He has a lesion in the LAD as well as in the large diagonal. And the RCA also had a significant lesion. So this is something very important. About 50% of the patients who have ST segment elevation MI, in addition to the culprit vessel, they also have lesion in their non-culprit vessels. And this was the case for this gentleman. So as we've already said, he had lesion in his LAD diagonal, and his RCA was also showing a 99% stenosis. So he had a fibrinolytic therapy, and the vessel did open up, but there was a residual 99% stenosis. And this we have to remember with fibrinolytic therapy. If you use streptokinase, in 50% of the cases, you will have successful thrombolysis. With tenecteplase, obviously, the success rate will be higher, 60 to 70%. There is a 20% chance that your vessel will reocclude. And that's why you need to do an angiogram for these patients to see what is happening. So here we have a patient who has already received fibrinolytic therapy. We see that his culprit vessel has a 99% lesion. His non-culprit vessel is also involved, a very large LAD and a large diagonal. So which vessel should we treat first? The rule is that you treat the culprit vessel first, and that's what we did. And we opened up the vessel. Here also we did direct stenting. We deployed our stent. We did post-dilatation. Our vessel opened up, and this was the final result. So did we treat the left side on the same day? Well, we did not, but during the index hospitalization, 3 days later, we treated the left side. So we could have treated all the vessels together on the same setting, but here we chose to do this because this patient had some issues with chronic kidney disease, and we didn't want to increase his contrast load by doing 3 vessels altogether. And so we did these 2 vessels. We tackled the left side 3 days later. And this was the final result. So how do we treat patients who come to us with ST segment elevation MI? If the patient comes to us with ST segment elevation MI, and if he comes within 12 hours or even within 24 hours, if he's in cardiogenic shock or having ongoing chest pain, then what do we do? If the patient comes to a PCI capable hospital, and if the patient is willing, of course, we offer the patient primary PCI. But here, we also have to remember that time is muscle and we have to be prompt. So our target would be from the first medical contact to our balloon dilatation, the time should be less than 90 minutes. So it's no use if you keep your patient comes and you're keeping him lying in the emergency, and then you're doing your own routine work, and then you ask the patient to come up, then all the myocardium is lost. So time is of essence, and our mantra is to do from the first medical contact to balloon dilatation, it should be less than 90 minutes. And primary PCI obviously gives you the best results. Now, what happens if the patient goes initially to a non-PCI capable hospital? Now, if the patient goes to the non-PCI capable hospital, however, you are able to transfer that patient to a primary PCI capable hospital. Lots of hospitals work in a spoke and hub kind of relationship. So you can send your patient to a hub hospital and they will be doing the primary PCI within 2 hours of first medical contact. Then the best thing is to send that patient to that hospital so that the primary PCI can be done. However, if the patient cannot be sent to a hospital and you will not be able to do primary PCI within two hours, then the best thing is to arrange for fibrinolytic in your own hospital. And your target should be that the draw to needle time should be less than 30 minutes. Now, what happens if the patient has failed thrombolysis, and how will we understand that the patient has failed thrombolysis? If the patient has ongoing chest pain, or there is no ST segment resolution, or the patient is having different types of complications, then we understand that this patient has had failed thrombolysis. And so to rescue that patient, we should send him immediately as soon as possible to a PCI capable hospital where his angiogram will be done and rescue PCI will be done. But what happens if the patient has a successful thrombolysis, like our banker who went to MAG Osmani Hospital at the middle of the night and was successfully thrombolized? Now, for that kind of patient who's also been successfully thrombolized and is also stable, that patient should also be sent as soon as possible within 3 to 24 hours to a PCI capable hospital where he will undergo an angiogram and his lesion will be delineated, identified, and it will be treated. And this is known as a pharmaco-invasive strategy. So you treat the patient initially pharmacologically, that is with your thrombolytics. And once that has been done, you ship your patient within 3 to 24 hours to a PCI capable hospital, and the PCI is done. And this is the pharmaco-invasive strategy. So pharmacological reperfusion with an invasive backup, and both the SEC and ESC guidelines recommend this even after successful thrombolysis within 3 to 24 hours. And I feel that in Bangladesh, this is the way to go, and it really works well. And so what happens if someone did not receive any reperfusion therapy? Should we do an angiogram for this patient? Of course, if the patient is in cardiogenic shock or has severe heart failure, then we should do it. If the patient has high risk or intermediate findings on pre-discharge invasive ischemic testing, if the patient has spontaneous or easily provoked myocardial ischemia, if the patient has failed reperfusion, or there is reocclusion after fibrinolytic therapy, and even in stable patients with successful fibrinolysis before discharge, we should try to arrange for an angiogram. So pretty much all patients who come to us with an ST segment elevation MI, we should definitely arrange for an angiogram and see what the territory looks like. And so patients who, this is indeed, so for cardiogenic shock, for spontaneous ischemia, we've already said that, and also for patients who have successful thrombolysis as a pharmaco-invasive strategy, patients should receive thrombolysis. Now, this one thing about primary PCI is we have to remember is that primary PCI is most beneficial when the patient is at high risk and when there is no other option. And in those end-stage scenarios, primary PCI can really be a miracle worker. Like in this 43-year-old gentleman who was rushed to the cath lab in a collapse stage. The ECG in the emergency showed that he was having ventricular fibrillation. After defibrillation, patient developed complete heart block. Temporary pacemaker was done. As CPR was going on, and you can appreciate the heart is barely moving, a shot was taken. And you could see that the left main is occluded from its origin. Heart was barely moving, CPR was going. We managed to wire the vessel. So after wiring the vessel, and here I would like to say that also give intracoronary adrenaline to this kind of patients really works well. And we usually give it in the, we dilute it 20:1 and give it. Balloon dilatation was done. After balloon dilatation, intracoronary adrenaline, the heart started moving a bit. Stenting was done. And this is the result. And this patient walked home 5 days later. So primary PCI would be the preferred mode of treatment in ST segment elevation MI and better than fibrinolytic therapy when the time to delay, the time for treatment delays are short. It should be done in a high volume center, which is well equipped with trained, experienced interventionalists and skilled support team. And why is it better than fibrinolytics? Because it allows a higher rate of infarct artery patency, better than fibrinolytics, obviously. It allows greater TIMI3 flow. And when you open up a vessel properly, there are lower rates of recurrent ischemia, lesser chance of reinfarction, lesser chance of emergency repeat revascularization, and also lesser chance of intracranial hemorrhage and lesser chance of death. So there is survival benefit as well. And when there is an early successful PCI, it also greatly decreases complications that result from longer ischemic times or unsuccessful fibrinolytic therapy. So you can easily discharge your patient earlier, and the patient can have an early resumption of daily activities. And as I was saying in the last case, which we showed, primary PCI has its greatest survival benefit in high-risk patients. Now, obviously, nothing is complication-free, and also there are potential complications of primary PCI. Well, what could those complications be? You might have problems with the arterial excess site. There might be adverse reactions to volume contrast medium overload or anti-thrombotic medications. There might be technical complications. There might be reperfusion events, or there might be no flow phenomena. Now, just to highlight the no flow phenomena, this was a 70-year-old male. His ejection fraction was 49%. He presented to us with acute anterior septal ST segment elevation MI. So this is the case, looks pretty straightforward, right? There's a tight lesion in the LAD, it's anterior MI, the patient has chest pain. So we thought this was a open and shut case. We wire the vessel and we do direct stenting. And that's what we did. We did direct stenting with a 3x30 drug-eluting stent. We went up to 40 atmospheric pressure. And as soon as our balloon is deflated, we see that the patient, there is slow flow. Patient becomes no flow actually. Patient becomes hemodynamically unstable, complains of chest pain. So what to do now? We immediately took our aspiration catheter. We used intracoronary adenosine, and we managed to open up the vessel, and this is the best we could do. So obviously there was a lot of distal embolization, even though we had done direct stenting, and which resulted in slow flow, no flow. So when you're dealing with the ST segment elevation MI, the best thing is to do, if there is a lot of thrombus load, you would use a thrombus aspiration catheter. So routine use is not done, but for high thrombus load, we still use thrombus aspiration catheter. And also we always try to do direct stenting, and we should go very slowly with our balloon so that there is no distal embolization. Unfortunately, here there was, and when there is distal embolization, you need to treat it with intracoronary adenosine, intracoronary nitroprusside. There's quite a lot of drugs. So why does the no reflow phenomena occur? it refers to what is the no reflow phenomena. You usually get this for short notes in the exam. So the no reflow phenomena refers to suboptimal myocardial perfusion despite restoration of epicardial flow in the infarct artery. It occurs due to inflammation, endothelial injury, edema, atherombolism, vasospasm, and myocyte reperfusion injury. The no reflow is associated with a reduced survival rate. And how do we treat it? We give GP2P3 receptor blockers. Nowadays, we also give it intracoronary. We use vasodilators like verapamil, adenosine, or sodium nitroprusside. Now, how do we know that our patient is clinically stable after PCI? Now, if the patient has good hemodynamics, is free of chest pain, then obviously we know that the procedure was successful. So this was taken from the ACCR guidelines. The clinical stability after primary PCI may be assessed with the absence of. So they're using a negative definition. So when you don't have any low output, you don't have any hypotension, no tachycardia, no shock, no arrhythmias, you can say that the patient is stable after primary PCI. And for examination purpose, understand a few of these definitions, like what is first medical contact, what is the primary PCI. So this is a very favorite question of examiners. So primary PCI is emergent PCI with balloon and stent or other approved devices performed on the infarct-related artery without any previous fibrinolytic therapy. So primary PCI definition is asked in the exams, and so is the rescue PCI. What is that, and what is pharmaco-invasive strategy? So we need to know these definitions, and we've discussed that already. And so we've also know that ideally we would try to do reperfusion within 12 hours, and it is better than fibrinolytic therapy, and we should always try to attempt to do that. And in case of patients with recurrent ischemia, with cardiogenic shock, with the life-threatening arrhythmias, we do it even up to 48 hours. And a routine primary PCI should be considered, as I was saying, up to 12 to 48 hours after symptom onset, especially if the patient is in cardiogenic shock. And this is taken from the 2017 ESC guidelines. And some important time limits, we also need to know what is the first medical contact to ECG diagnosis. It should be less than 10 minutes. What is the maximum time from door to balloon, from first medical contact to primary PCI? What is the time from door to balloon? So all these time limits we should remember. And which are, if, as I was saying in the second case, multi-vessel involvement. And this will happen in 50% of our patients. So which vessel should we treat? Obviously, we should treat the infarct-related artery first. And in fact, the patient is symptom-free and stable, and we want to, and has multi-vessel disease. Depending on the operator's discretion, the non-infarct vessels can also be stented. So what should be our technique to stent? When primary PCI first came about, there was a lot of debate about whether we should just do POBA, just do balloon angioplasty, or should we put a stent? But obviously studies have definitely shown that stenting is better over balloon angioplasty in case of primary PCI. And what stent to use? There was a lot of debate about whether we should use bare metal stent or drug-eluting stent. But studies have also shown that stenting with new generation drug-eluting stents is better than using bare metal stents in case of primary PCI. Now, what route should we use? We should use the radial route, because with the femoral, there might be excess site complications more. Thrombus aspiration, as I've already pointed out, routine is not recommended, but it is dependent on the operator's discretion. And also routine deferred stenting is also not recommended, but this also, if the operator thinks that there is too much thrombus burden, the deferred strategy is sometimes used. And what about the non-infarct vessels? Well, you can do it during the index hospitalization before discharge if you want to, and the non-infarct related arteries can be even done during the index procedure if the operator thinks that it is suitable, and patient can also be sent for CABG if the patient is not a suitable candidate for PCI. And so this has already been discussed. And what else? So what drugs do we give during the primary PCI? We always give the patient aspirin, and we also give him a potent P2Y12 inhibitor, which can be prasugrel or ticagrelor. And if the patient or clopidogrel, if prasugrel or ticagrelor are not available. And we need to remember that in Bangladesh, around 30% of our population is clopidogrel resistant. About anticoagulation therapy, Kalim has already touched upon this, so I will not go into details, but we need to remember that in patients where we suspect heparin-induced thrombocytopenia, we should be using bivalirudin. So that's all about invasive strategy for ST segment elevation. And from the entire team of National Heart Foundation, thank you for giving us this opportunity to present our lectures. Thank you.
Thank you, madam, for your, as usual, brilliant lecture on ST segment elevation MI. For the student, this is a very important topic, medical management and intervention of ST segment elevation MI. Now, comments from Professor Ghulam Azam, who is the expert panelist and as the examiner perspective. Professor Ghulam Azam, please can you say some questions and discussion about these two topics for our students, and they will be benefited from your talk. Professor Ghulam Azam.
On the and let's cover how. Can you hear me?
Yes, we can hear you.
And Madam also covered ST elevation MI in the part of both revascularization strategy, mechanical revascularization strategy as well. So actually it is a medical emergency. So we have to know how to, at least we should approach, and we have to manage customized way where we stand. Suppose no one, not always everyone stay in bigger hospital like Metropolitan City Hospital like NSCBD, Heart Foundation, Biounit Hospital like that. So we should everyone know how to manage every case estimation MI in their settings, in their hospital settings. Suppose there is a district hospital or a Upazila hospital, and what should they do? What is the best option for the patient that time? So I just ask a colleague, suppose a patient work in a Jinaidha, that is the very remote area in the Bangladesh. There is a estimation MI, emergency medical officer of Upazila helicopter officer. What should they do in that particular situation?
Regarding loading dose, you should give aspirin and clopidogrel. And streptokinase, if there is a CQ setting or if there is monitor, they can use streptokinase. And now in our country also available tenexaplase, which is single bolus dose. You can give this bolus dose and transfer the patient in PCI capable hospital for Pharmaco therapy.
Thank you, Kalim. Actually, right now we are doing this, but our recommendation antiplatelet statin that should be given in any center, any place, anywhere. But regarding lytics, either we should go for thrombolytics or go for primary PCI. If we consider that is not best the time, so we should consider thrombolytics first. Then we transfer the patient as soon as possible. They are nearby center. That should be the standard practice from our side, number one. Number two, regarding lytic thrombolytics, because tenecteplase is much more easier than streptokinase. So we should prefer it, we should encourage it, and we should motivate our people. Though it is, even though it is expensive, but it is patency rate is much more higher than streptokinase. So we should take some program, educational program, so that our people can be motivated, as well as our physicians are also motivated, because our physicians are some extent inertic for this, go for this updated drug therapy. So I recommend everyone, we should encourage everyone to use it much more. And thank you very much.
Thank you, Ghulam Azam. We'll come to you later on. Professor Rahiduzzaman, sir, please. Sir, are you with us? Rahiduzzaman, sir. Professor Ashok Kumar Datta.
Yes,
Ashok,
thank you.
Any comments or any suggestion?
Yeah, thank you, Dhimanda. Thank you, Dhimanda. Thank you.
Yes, thank you.
Great lecture from Pujila ma'am and from Dr. Kolimuddin. Dr. Kolimuddin actually included all parts of the acute MI, including its complication, how to manage it, and complication, how to manage it, and up to the 40 days ICD. So everything is covered by Dr. Kolimuddin. What Ghulam Azam was telling, sometimes it is something very much important for the student. And madam, actually, that is great. If you remember, for the student I am telling, if you remember few cases only, what madam showed 3 or 4 cases, if they can remember these cases, they can just answer the question by remembering the case or history. That is very important. Few cases, if they deal from A to Z, that means from admission up to the discharge and follow-up, then that is very much impressive to memorize it and to recapitulate it. If the student can deal with the patient, madam, just what she showed, that is excellent way. What is slow flow, how to manage acute MI with complete heart block, how to manage acute MI with cardiogenic shock. These are very commonly asked questions in the examination. So everything of, there is one thing like everything of something you have to know. Acute MI, acute coronary syndrome is such a topic. Everything of this acute coronary syndrome, all students should know. Regarding tenecteplase and streptokinase may be asked, because tenecteplase now getting very popularity. Regarding antiplatelet, clopidogrel and ticagrelor, which one will you give as a loading dose? That sometimes may be asked. What are the advantages of ticagrelor? That may be asked. These are the very important topics that the students should remember. And other thing, what are the indication of low molecular weight heparin after giving streptokinase? In all patients with tenecteplase, you have to give low molecular weight heparin. But after streptokinase, low molecular weight heparin is not indicated for all the patients. What are the indication after streptokinase? That is commonly asked also. So actually, I have learned a lot from both of you, Madam and Dr. Kolimuddin. And for the student, I'll tell that most of the things have been discussed. Most of the things, all the points have been discussed, and you have to remember the thing that is more important for you. And definitively, everything, at least you should read all the things that is discussed today. Thank you, Madam. Thank you, Dr. Kolimuddin, and thank you, Dhimanda.
Thank you, Dr. Ashok, for your brilliant suggestion. Before going to other panelists, to the students, I have some talk, because this topic is very important. From this topic, no questions will be asked directly. you will be given a problem and you should solve the problem in the written or in the Viva table or in the OSPI, such as Dr. Gula, which has been 10 marks question for student in the patient with ST segment elevation coming to you in a district hospital or in Upazala hospital. How will you manage this case? And the common another 2 or 3 questions in the Viva table or in the or in the written, there will be with a problem. And in the written or in the Viva table is with a complication. You say a patient in the emergency department comes with VT and given CPT elevation in 6 question for in written and in the Viva table, giving this that the absolute contraindication of streptokinase are there, and you will manage this case. Another important is topic regarding the you should know the contraindication of this drug. Dr. Kolim and Madam has absolutely answered this thing, and the flow chart the Madam has given the time. This is commonly asked in the Viva table or in the written or in the OSPI. Now I have seen the Rahiduzzaman sir. Are you there? His sir is there. Dr. Rahiduzzaman. Dr. Ishraq, are you there?
Sir, I'm here, sir. Thank you, sir.
Yes. Ishraq, what are students in this common topic?
Sir, there is one question.
Actually, it's been beautifully actually, but explained, described by Professor Fibrinolysis Malik, Madam, and also Dr. Kolimuddin. So, if it's concerned with the emergency medical officer, actually in these lectures, actually everything is there. What to do, when to do, how to do. So I think if besides medical MD students or others, I think each and every doctor should have these lectures so that they can easily manage these patients with acute MI. So I think thank you, Madam, for beautiful lectures as usual, and Dr. Kolimuddin, thank you. So I think that's all, sir.
Sir, one question in chat box. Is there any recommendation for the use of prasugrel or ticagrelor after PCI of chronic coronary syndrome? Today our discussion is on STMI, it is acute coronary syndrome, but I will answer this question. Usually in chronic coronary syndrome, clopidogrel is a class 1 indication. And if patient have high risk of stent thrombosis like suboptimal stent deployment, complex left main PCI stem or multivessel stenting, or if DAPT cannot be used because of aspirin intolerance. In that case, prasugrel or clopidogrel can be, prasugrel and or ticagrelor can be used, but it is 2B indication. For chronic coronary syndrome, clopidogrel is the class 1 indication as P2Y2 inhibitor.
So thank you, Dr. Kolim. Azam, Professor Azam, have you any comments? Professor Azam?
No, actually, this question answer is, I think it is almost okay, but actually the participant want to know which drug we should prescribe. I think so far if I can understand the question.
For chronic coronary syndrome, according to ESC guidelines, clopidogrel is the a drug of choice class 1 indication, and prasugrel or clopidogrel is class 2B indication In case of suboptimal stent deployment, if there is high risk of stent thrombosis or complex left main stem or multivessel stenting, in that case, prasugrel or clopidogrel can be given.
Now, anyway, I got your point. Actually, in chronic coronary syndrome, if you
Yes, sir.
wish to continue DAPT, it depends on actually the clinical scenario. Either you have to think of the thrombotic events and bleeding risk. You have to understand what is the
Yes.
risk between this thrombosis, risk of thrombosis and risk of bleeding. If you think it is not a high bleeding risk category, then you should consider actually SAPT. SAPT, that means single antiplatelet therapy. If you consider ecosprin, clopidogrel, prasugrel, ticagrelor, whatever you like, but you should be judicial to prescribe your patient whose drug is best, because for the price and safety margin, clopidogrel is the best drug in terms of other drugs, but you can continue either clopidogrel or prasugrel or ticagrelor, but not this same mode of action drug. You cannot prescribe two drugs simultaneously. That is my take-home message for the participants or our students or our fellows. You should assess what is the indication to continue your DAPT. Then you should find out the thrombotic risk. Then you should find out the long-term bleeding risk. Then you try to find out how to compromise. You should follow the Goldalic maneuver. Then you can decide how long you should continue your drugs and which drug you should prefer according to your experience and price complications. Most of on the top of the I think that is my comments. Yolanda, can you add anything more? Ed?
No, no, it is okay. Madam, are you here?
Yes, I'm here.
Yes. Madam, are you?
Yes,
Madam,
yes,
can you
can you hear me?
close this session?
So thank you. I'm glad that
Madam,
Professor. Hello.
say some comments and you can close this session.
So thank you, Professor Azam, for joining us and giving us your knowledge and sharing your knowledge with us. And thank you to all the audience, and thank you, Dhiman, for being a moderator. And this is our 50th session and our last session. So I think we can conclude. Thank you so much. So Dhiman, you can say your concluding words and we can close it. Yes, thank you.
Thank you, madam. Thank you madam for your brilliant lecture, and Dr. Kolimuddin for your nice speech, and Professor Ghulam Azam for coming us.
Bye.
Bye. Thank you, Yolanda. Bye.
Bye.
Wish you a great journey.